Excellent. Thanks, Eric, and thanks for everyone for coming. So I'm doing a little pitch hitting. I'll give another talk tomorrow, but I figured we start off kind of a little intro on Chiari and then kind of talk about a big major problem after Chiari surgery is not effective, basically. So as Eric kind of said, I'm from the University of Iowa. I am a pediatric neurosurgeon. But I treat all ages for Chiari and Syringomyelia. So infants, basically, I say it all the way up to 90-some years old, and surgeries that I've done. So, just an intro, what is Chiari? I know a lot of us know this, but I'll kind of give you my spiel that I give to all my patients that I interact with. So, the Chiari malformation type 1 is the most common type. This is kind of variable, but, maybe up to 4% of the population has it. So 1 out of 25 people, which is a significant amount. But not everyone, of course, is symptomatic from it, right? And so there's a spectrum. It's, defined radiographically as a herniation of, cerebellar tonsils more than 5 millimeters below the foramen magnum or the opening in the skull. And this is just an example here showing Chiari here on the right. And this is normal, right? So the Chiari malformation, as I kind of say, is that the brain is just too big for the skull. People are just too smart with Chiari. That's the problem, right? The brain is too much. So it goes down through the opening of the skull. And in this case, it's formed this very large syrinx here. And all this can cause problems, which I'll kind of talk about as a quick overview here. So it's really a congenital developmental abnormality. It's really not thought to be like an abnormality of the cerebellum or the brain. It's really thought to be a bony problem or a really intradural scarring problem. That's the most common thing that I would say we typically see when we see Chiari in the clinic. It's that, again, the brain's too big for the size of the skull. And there's a component where there's also scarring that occurs at this site here. That's partially from the herniation of the tonsils and the brain being too big, and that forms scar tissue here. But there appears to be, because it occurs in really even very, very young kids, that may be part of really the pathophysiology of Chiari. And people with Chiari may have a little bit higher inflammatory state, and they create a lot of adhesions, maybe after a traumatic birth or something of that nature, and the blood pools down here. That creates scarring around the tonsils, and that kind of plugs the outflow of fluid from the brain. And that fluid can't get by, and then kind of pushes those tonsils a bit further into the foramen magnum, essentially causing obstruction of flow and then Chiari malformation. I always say it occurs before 5 years of age, so this is the congenital developmental type of Chiari malformation. Because kids are just, when they're born, the bone is more cartilage, it's more pliable. They don't have this defined kind of skull pattern here in this teenage girl, and the Chiari is still kind of forming. And so usually by 5 years of age, if someone doesn't have a Chiari, they aren't going to develop a Chiari malformation. And so as the bone thickens and changes in the first couple of years of life, that's when the Chiari can kind of set in. And so on. It really changes over the course of the life. So radiographically, you're going to see the tonsils after 5 years of age is going to stay the same location for essentially the rest of life. The only time I say that I've seen it change is someone, a bodybuilder, a lot of Valsalva maneuvers over many, many years, a lot of heavy weightlifting, did push the tonsils further down, and that patient became symptomatic. And then I've seen it with someone that's gained hundreds of pounds of weight. The tonsil, because that increases the pressure in the brain, that will push the tonsils further down by millimeters, not just a small amount, but a large amount. I've also seen people then get gastric bypass and lose hundreds of pounds, and I've seen then the tonsils will ascend. Those are really the only two examples. They're kind of extreme examples. There's not very often, rare examples. Patients present in from 1 to 70 years of age now, and I see older and older patients almost every year present with Chiari. That's just a function, I think, of MRI and basically being popular, being developed in the 1980s, and then really only being with good imaging in the 1990s. And so a lot of the people that are older didn't have MRI when they're younger, and so we're kind of seeing that now as they kind of present older. The symptoms, as I said before, extremely varied. The most common, though, is a headache, and so on. So this is the the quick overview of imaging for Chiari, right? So Here's the brainstem. Here's a cerebellum. This is the brain. The nose is this way, and this is the mouth. So this is a slice that goes right down the middle. The back of the head is here. This little white box is enlarged over on this side, okay? So we can kind of zoom in on what were really the important parts here. This dotted line is the opening of the skull, and you can see the cerebellum goes below the opening of that. Oftentimes, this can be very flat and kind of pushed in. You can imagine we wouldn't really have a Chiari malformation. This bone was kind of more angled like this, and didn't kind of come in like a shelf. But that basically creates the shelf in the cerebellum, not enough room, and so it goes to the opening of the skull. You can see what happens here. This creates a thinning of the medulla of the brainstem. So it's the bottom of the brainstem, and it creates this kind of, it pushes the whole brainstem down this far, almost down below C1. The end of the brainstem should be up here, okay, really at the opening of the skull. And so we call this like a cervical medullate buckle. It's like when your foot basically goes into sand and it pushes sand forward. It creates a little bit of a mound of sand. And that's what you're trying to see here, seeing a mound of basically a brainstem. So there's brainstem compression here, and that will lead to different types of symptoms. People don't have this type of radiographic findings. It's hard to, they're going to have a different presentation. So this is just showing some variation of some recent patients I just saw. And I quickly just kind of put this together in the last 15 minutes. So both of these are 3-year-old kids. On the left here, you can see significant tonsil herniation, almost all the way down to C2. This is about 20 millimeters or so of tonsil herniation, and there's brainstem compression. This patient presented initially with headaches, if that were migraines, snoring, sleep apnea, other brainstem dysfunction type of symptoms, and really severe headaches. This child here, kind of on the right, has the syrinx, right? So you can see over here, there is no syrinx. That's this fluid cavity in the spinal cord, right? And there is no syrinx on this patient, but there is in this patient, right? Tonsils kind of come down. Again, these are the same age, right? They don't even come down as far as on this side, okay? And you can see this large syrinx. And this child here presented actually with no headaches whatsoever. They presented with symptoms from their syrinx. So parents noted, and this is kind of an acute presentation. This is more chronic. So this child kind of in the last 3 weeks have developed balance problems, gait instability, developed swallowing problems and snoring issues, and things like that. But the biggest thing the parents noticed is like just its balance, which is much worse than the last month. So, we talked about this, the headache, that's the most common symptom of Chiari. Suboccipital headaches, they occur in the back of the head, brought on or worsened by Valsalva maneuver. So what is that? It's coughing, laughing, sneezing, crying, straining, or kind of exertion, which you might see in kids. And the symptoms differ by age, right? So the very young children, they have a difficult time expressing themselves. It's hard to know if they have a headache. They may grab the back of the head. It's kind of common if they have a headache. They may scream or something if they're playing and their head goes back. But they also may have problems swallowing if it's a very severe Chiari and there's that brainstem compression. And if they have swallowing difficulty, they may fail to thrive, right? So it's something to look out for. And sometimes the headache, difficult to express in kids, can be translated as constipation, abdominal pain, other things like that, because they do not want to go to the bathroom, right? They don't want to try to have a bowel movement. They are, because that hurts, right? That creates a Valsalva maneuver and they have to get a headache, so they hold it basically. And that leads to constipation over time and more abdominal type symptoms. And what are the other symptoms besides headaches, right? So the next most common symptom that I see, and this is pretty much across the board, if they, is a swallowing difficulty, right? And that's because there's really pressure on the brainstem, and that swallowing, those nerves that go for the swallowing, which is very, very complex of a function, occur right at the bottom of the brainstem. Snoring is also common, and the same kind of thing from brainstem compression and dysfunction. Same thing for sleep apnea, which is a brainstem dysfunction, and this hoarseness and decreased gag response is also from brainstem dysfunction. The patients that can develop scoliosis, and that can be from a large syrinx that formed that I showed you before, because that weakens the actual nerves that come out from the spinal cord. It weakens the anterior horn cells, which are these little areas, the beginning of neurons that are in the spinal cord that go to all the muscles around the spine. Those muscles are weaker, then the spine's weaker, and it will develop a curvature to it. And then, the Chiari itself probably has a little bit of pressure on the brainstem in some cases, like I showed you there, would also lead to weakness, right? Weakness of those spinal muscles would also lead to scoliosis. There's many other symptoms. The cerebellum plays a role in many cognitive processes. We know that taking out tumors in other individuals and kids and adults, certain locations are very, very critical, and they can have a lot of significant cognitive dysfunction if those areas are affected. So the same thing could happen potentially with Chiari. So, what's the surgical treatment? We, as a lot of people know, we do a linear incision in the back of the neck, take off just this area around the foramen magnum. It doesn't have to be a large decompression. This is the critical area. Like I showed you before, that bone kind of comes in here in some cases. The bone can come in on the sides. And this is really kind of the meat and potatoes of what the issue is. We take off either part or all of the first bone in the neck, C1. And then there's this the covering of the brain, and there's a tight ligament there that gets removed. And then in some cases, we can just thin out the outer covering of the dura, and that's good enough. And we use ultrasound, and we say, is that a good enough decompression? If it's not, or if the patient has severe symptoms or a syrinx, we often open up the covering of the brain, which you see here. This is an intradural opening. And oftentimes, as I described before, there's a lot of scarring here. And the scarring has to be removed to open up the flow of the fluid to flow past. And then a patch will be placed, and there's different types of tissue that can be used. This is kind of an old number here, but I maintain this database of all our patients that I treat, both kids, adults with Chiari. And I think we're up to, and it's not just from me, it's from myself and from my mentor, Arnold Meneses, who's treated a lot of patients at IA for decades. I think we're up to around 500 or 600 patients at this point. This is showing part of the surgical approach and the incision in the back of the neck. And we take off this covering of the muscle. It's called fascia, and that's what we use for a duroplasty. Once we open the covering of the brain, there's all these adhesions that can be taken down. And here's just showing an outlet of the fourth ventricle. This is a complete occlusion of that. And so that's the importance in some cases, especially kids or adults with syrinx, to open up the fourth ventricle and remove these adhesions that are preventing the normal flow of fluid. And then this is just kind of showing placing this patch right on the covering of the brain to give more room for fluid to flow, more room for those tonsils. And this is kind of what you see pre-op, and this is what you want to see post-op, right? So there's that case I showed you before, that large syrinx, tonsil herniation comes down in here, very, very normal looking cerebellum, tonsils have kind of risen up. You have this normal CSF around the tonsils, around the brainstem. There's no more compression of the brainstem, and that syrinx is completely gone. So what complications can occur with Chiari surgery? And I think everyone that does Chiari surgery, they have their little tricks. But there are some tricks that are absolutely, I think, vital for everyone to have success with Chiari surgery, that people that I think have great success all do. And the difficult thing about Chiari is that it is very unique. I think the patients are unique. Like I said before, they have potentially have this pro-inflammatory state. So any little bit of blood that goes intradural or inside the covering of the brain during surgery has this risk of developing adhesions. And that is what leads a lot of times to failed Chiari surgery. Now, when we do tumors and we take out tumors in the back part of the brain, the same location, there's lots of blood that's there and that goes intradurally. Yet it's interesting in those patients, they don't develop the same adhesions and problems. So there's something unique about the Chiari patient that leads to these major issues where you have to be so careful with surgical technique. So, one of the biggest complications is recurrent adhesions and scarring that occurs intradurally. And I'll show you some cases of that. Aseptic meningitis, which is a non-infectious type of meningitis. And that's often from muscle protein that probably gets intradural during the surgery, or some blood that gets in intradurally during the surgery. There's bacterial meningitis, which is much worse. And that can lead to lots of scarring, and then that will lead to multiple surgeries. One of the big fears is the CSF, the brain fluid, leaks through the incision. So there's fluid all through here, and if you open the covering of the brain, that fluid then can leak out, and it goes out through the covering of the skin. Well, if it leaks out through the covering of the skin, bacteria can get in, and that can cause infection. CSF can also create a big fluid pocket back here. maybe doesn't get out through the skin, but it creates a big fluid pocket in the back. And the problem is that will then push out all the muscles out laterally. It will then basically destroy the muscle that's there. And those patients can have kind of recurrent or persistent neck pain because muscles are no longer really attaching then to the skull, right? And so patients feel like maybe they have a little bit of a bobblehead, and that can be a major issue. Hydrocephalus is another one that's buildup of fluid in the brain that will require additional surgery. Again, if muscle isn't closed properly, or you get that pseudomeningocele, then you can have craniocervical instability requiring a fusion. And I think not recognizing associated conditions with Chiari is a major one that I see, and that's all these bony abnormalities, ligament abnormalities that occur, and people treat the Chiari rather than treating both the bony abnormality, the ventral brainstem compression, the instability, in addition to treating the Chiari. They don't do both. They may just treat the Chiari, which can be a problem. And then patients who have persistent symptoms or worsening symptoms from continued brainstem compression, block of normal CSF flow, enlarging syrinx, from all those things that I showed you. We've, like I said, we've done about maybe 500 or 600 surgeries now. The complications are pretty rare from our series, and there's different series and so forth, but I'm just going to talk about ours. Aseptic meningitis, only one patient out of this 469, and we haven't had that even since now. So 500 some patients, CSF leak only in 2, and none really leaked through the skin. They were just created a pseudomeningocele. Some superficial infections only in 2 patients. So you can see, hydrocephalus 0%, craniocervical instability 0%, less than 1% really a risk or a complication from these types of surgeries. So you can see that, I think in some cases, complications can be rare, but if they do occur, and I'll show you examples, it can be quite severe. So aseptic meningitis, this is again the non-bacterial meningitis, is not an infection, but it causes similar symptoms to bacterial meningitis. So nausea, vomiting, headaches, neck stiffness, and fevers. And this can be persistent and it can occur days to weeks after surgery. And usually we just give a course of steroids that will help. The bigger things are, again, the bacterial meningitis, or like a CSF leak through the skin that leads to infection. And this is just kind of showing, this usually occurs kind of very soon after surgery, within days to weeks. Can result in that meningitis. This needs immediate attention, right? So if something's leaking through, bacteria can get in, and you do not want bacterial meningitis, right? This is the worst. Placing a lumbar drain, that's a thought. That's a drain that goes in the back and helps drain the fluid through the back instead of draining out through the skin incision. So it does that in a very controlled way. You place a needle. The problem with that is that that's down in the lumbar spine, right? And you're draining fluid. When you drain fluid and pull fluid down, you also will pull the tonsils further down, and that may lead to scarring after surgery. So this is why the CSF leak through the skin is very, very difficult. Sometimes that requires someone you have to go back in and redo a surgery, find the hole, patch the hole. Sometimes it requires to place a temporary drain at the top of the brain, not the lumbar drain, different. And then maybe place a more permanent shunt that shunts that fluid, and so that fluid leak can heal. So the other thing, if it doesn't leak again through the skin, it can leak and cause a fluid pocket in the back of the neck. And so it gets trapped underneath the skin. This destroys muscular attachments. Then this leads to this kind of occipital, cervical, or craniocervical instability. It can also cause neural compression. Can cause scarring of the cerebellum to the dura. Because you're getting fluid that leaks out, and so that fluid will then pull the neural structures posteriorly, and I'll show an example of that. It'll pull the brainstem posteriorly and the cerebellum. This can cause surgical failure, recurrent syrinx, which I'll show you, and then this needs surgical repair in some cases. Other cases, you kind of can let that pocket scar down, and hopefully it does, and then kind of redo surgery at that point. So here you go. This is that CSF leak causing the pseudomeningocele and then craniocervical instability. So this is a large fluid cavity. This is not leak. Did not leak through the skin. Okay, you can see that here, but you can see how close that is. It's incredibly close. Now, what's supposed to be here is lots of muscle. There's an incredible amount of muscle that goes through our neck, that goes through all these bones here, okay, that attaches to the skull. Now, you can see they're not attaching at all to the skull, all the way up to here. They're not, right? They're being destroyed and they're pushed out and they get scarred out this way. So you can't just go back in and try to close this muscle together because it's not going to come together because it stayed like that, okay? You can probably see there's maybe a little bit of a hole here or something like that. Well, this patient we treated with Diamox, which is a medication that reduces the absorption of, helps to reduces the production of CSF. You can see this is the same patient. This got scarred down here, okay? Well, you can see what happened. And I think before this patient initial surgery wasn't with us, but I still don't have those images. But before even the first surgery, they had this large syrinx. The syrinx went away because the fluid doesn't have to go through the spinal canal anymore. Now it has an outlet to go back in the skin. Okay, so there was some pre-op, I think, that did show a large syrinx. The ones that did scar down, the fluid couldn't go any out here anymore, so it had to go down through the spinal cord, right, causing a large syrinx. And you can see here, this is at the junction of the brainstem and cerebellum, or brainstem and spinal cord. This patient had severe deficits. And you can see there's no muscle here. It's all gone, okay? And all this is scarred. And then you can see how thin this is, right? This should be way out here. There should be a lot more attachments, right? So you can see the kyphosis that's occurred already in the cervical spine. And so this patient required then going back in, lysing adhesions, and re-exploring the fourth ventricle, opening the fourth ventricle, proper dural closure, and then we did an occipital cervical fusion with rib graft. Symptoms dramatically improved in this patient. So here's another example of pseudomeningocele. And again, these are very challenging cases because you can see what happened here. This is pre-op, had a little bit of a syrinx here. This is a very large fourth ventricle. Brainstem's kind of pushed back a little bit posteriorly, but not that significant. Tonsils come down pretty far. Post-op pseudomeningocele here. You can see the brainstem in that little mound of the tissue. The cervical medullary buccal is now bigger. The brainstem's pushed back more. And again, we've destroyed all the muscle attachments here. And this is going back further because the muscles have been destroyed here. And now we're developing more of a kyphosis at the craniovertebral junction, okay? So this is signaling that there's instability here. And then the question is, when you look at this as a surgeon, what are we going to do? Can you go back here and do more of a decompression? I mean, this is the skin. And there's not much more you can do here. The problem sort of is here, right? This part that comes from in front. And so then we often will do flexion and extension imaging and see how much of a decompression, how much impression there is, and what the next steps would be. And ultimately, this patient required a very sophisticated, challenging kind of treatment plan. Required us from going in front through the mouth to take out this bone here, okay? Take out this bone here. This is pre-op. And then we went back from behind, explored posteriorly again, opened up the covering of the brain and spinal cord. We took down all these adhesions and scarring, opened up the fourth ventricle, closed this properly, and then did a fusion because of the instability. And you can see this is pre-op and this is post-op, and look how much better this is, right? Okay, this is what you want. The brainstem is nicely relaxed all the way to going down, and there's no more of that mound of tissue here. It's not being compressed. A lot of fluid around the cerebellum, and the alignment is significantly better in terms of how the craniovertebral junction looks, and the symptoms dramatically improved. So this is what happens when you get adhesions and intradural scarring. This patient was treated in 1997, initially as a 12-year-old boy, and then had three other surgeries, so a total of 4 surgeries. This person now is around 37 years old, and you can see there's a spinal cord here, but you can barely see it, right, because of how significant this syrinx has been, and for chronic compression. This patient is becoming essentially quadriplegic. The left side is essentially hemiplegic, cannot move really the left arm, can move the left leg somewhat. Right side is now becoming weaker, okay? And this will require a pretty significant operation where if they go down again and take down the adhesions and scarring, which you can see here is a big scar here. And ultimately what I'll do is place a tube that will go from that fourth ventricle. It's called a shunt, but it's operative intradural, a fourth ventricle to subarachnoid shunt, okay? So because the problem right now is this fourth ventricle, fluid can't get out, and then it's ultimately developing this pressure that goes, and fluid that goes into the spinal cord, okay? This is a child that was operated again 3 different times somewhere else, and they had major issues, a CSF leak and a big pseudomeningocele, and they placed a lumbar drain, again, a tube that goes down at the bottom that drains fluid, and you can see what's happened over time. This is a brainstem that's been now scarred to the back part of the dura, and the cerebellum that's been scarred back here. And so every time he flexes his head, there's more and more traction on the brainstem, okay? These are challenging kind of cases, but I can show you that when things go wrong in Chiari surgery, and really that first surgery is the most critical surgery, right? That you don't develop these kind of complications, because these become very challenging and high risk to treat. So Hydrocephalus, again, this is an increase in fluid in the ventricles after surgery, okay? So some patients have hydrocephalus before surgery, and oftentimes we should treat that hydrocephalus before we treat the actual Chiari. That's my practice, and that's a lot of people's practice, because it really decreases risk of complications after surgery if you treat the pressure in the brain before you do the Chiari surgery. But in some patients, they develop an increase in CSF in the ventricles after surgery. And so that can occur days to weeks after surgery, severe headache, nausea, vomiting. And this can be associated with a CSF leak, or again, that fluid pocket in the back of the neck called a pseudomeningocele. And why would it be? Well, patient, maybe you get during the surgery, there's some scarring that forms or some blood, like I said, that gets intradurally. And that causes some scarring and adhesions, again, in a very unique patient population, the Chiari patient. And that leads to increased pressure in the brain, increased fluid here. If there's increased pressure here, then that's going to force pressure and fluid out through the opening that was made in the covering of the brain, leading then to that CSF leak in the back of the neck, right? Which can lead to more problems. That pocket I showed you, or a leak through the skin, bacterial meningitis, and then on and on and on, which is bad. And oftentimes, these, if treated early, and hopefully you treat this, and without any of that happening, you just see, oh, there's hydrocephalus, you can treat that with a ventriculoperitoneal shunt. So another complication that can arise from surgery is craniocervical instability. And one of these is because there's patients, again, had that before surgery, wasn't truly identified. They had bony abnormalities that maybe the radiologist didn't pick up on because they can be kind of subtle, or CT scan wasn't done. And those cases where maybe it doesn't look like a Chiari, typical Chiari, and in those cases, those cases are where there's probably some bony abnormalities that are occurring there. And those bony abnormalities often predispose to having someone having then instability, okay? And if you don't do dynamic imaging, or you don't have someone do a flexion and extension, they move their neck in an MRI scanner, you may not see that movement, okay? And then another case could be it's developed after surgery, right? So one thought you would say was like, okay, well, you have to create more room for the cerebellum. You place this patch, you give more room, but all that muscle is there, why not just not close the muscle, or leave more room? Well, the reason why we can't do that is because that muscle is so critical to close. So that muscle is kind of just divided in the midline, but you have to close it and suture it together so that it heals together. If you don't do that, then you can develop instability. And it's the last thing you want to do, right? And say it's a child or a young adult, 5 years old, muscle isn't closed properly. Well, the rest of their life, they may develop neck problems, neck pain, and so on. Now, that's not the case for everybody, but you take someone who's thin, doesn't have much muscle to begin with, and they don't get that closure of the muscle, right? Well, their head still weighs just as much as a lot of other people, right? And that head is going to weigh then on the neck. And those people have issues. Now, in many cases, I will, in clinic, put them in a cervical collar, and their pain will almost instantly go away because it just supports the head. It's taking the action of those muscles, right? So, what you want to see is with the muscle all closed in a post-op scan, and you'll be able to easily tell that. It should be kind of the same thickness as it was pre-op, okay? This persistent syrinx, syrinx that goes into the brainstem, or continuum brainstem compression can contribute to instability, right? So maybe the muscle wasn't closed well enough, or pseudomeningocele form where the muscle attachments stayed open and they're not closed in the midline because of the fluid pocket that was there. Maybe it's just a small one, right? But all that adds up, right? You have someone that has then still persistent fluid in the spinal cord, their brainstem's weaker, their spinal cord is weaker. Again, those muscles then are weaker, right? Because they still can't get the same innervation. So it leads, all that is a contributing, multiple factors then that leads to weaker neck muscles. And then again, weaker neck muscles, you can't hold the head up. You're going to have more muscle spasms, more inflammation, and then more pain. On top of all of that then, right, the Chiari patients are unique, and many of them, and this is still like under study, right, but they have a lot of these other contributing factors. They have hypermobile spectrum disorder, right? They're more flexible. Their ligaments are looser, right? And they have other genetic conditions. We see Marfan's and Ehlers-Danlos and other things, right? That also add on top of all of that, right? And if you just had one of those things in isolation, it might not be a problem. You add all those things up, and that can lead to lots of issues. Okay, so as I said before, I treat with a cervical collar, and hopefully in the end that will decrease inflammation in the neck muscles. Ice the neck, that will help decrease inflammation in the neck muscles, because all that inflammation that's occurring, you hope that you get past that point initially of that neck pain, that inflammation goes down. You can try to build with neck exercises whatever muscle is left. Okay, and this is on a case-by-case kind of basis. If you can't build that neck muscle as much in the future than as you need to, then last resort is an occipital cervical fusion, and you try not to do that, right? So, you're going to reduce mobility of the neck for the rest of their life. But if that's the last thing, if that is the only thing that you tried everything else, all these conservative measures, and really this is a long conversation, and this is not something you just make on the first visit or something like this, but you say, okay, then we can do that, right? And we've done that, and not many patients, but some, and they've all done well. But these are very highly selected type of patients. This is just another example. Yeah, craniocervical instability. That is enlarging syrinx that was here after they'd done initial surgery. Somewhere else, I think when they saw me, it was something like 8 years prior, 10 years prior. Later, they were found out to have Marfan syndrome, right? So the whole family actually this patient, her father actually died early, and then they found out because it was from an aortic aneurysm. They found out, oh, wow, okay, that's unusual. And then the whole family is very tall, very thin, and they did genetic workup and found to have genetic mutations that be consistent with Marfan. And then, she still had this kind of persistent syrinx enlarged. You can see here, I'm not showing it, but on flexion extension, she had more ventral brainstem compression. And so ultimately, treatment for her was do decompression posteriorly, open up the covering of the brain, place a patch, syrinx goes away, and then we do a fusion, right, to stabilize her spine. You can see how much better that this looks on a post-op scan than what I just kind of showed you there before, okay? So here's pre-op, right, and here's post-op, and this looks much better, and this has kind of stabilized this region, right? So the one issue there is beforehand, the initial surgeon didn't know this patient had Marfan syndrome, right? A lot of patients don't know. They have some kind of other genetic condition that may put them at higher risk for a complication post-op. And again, I mentioned these are these associated bony ligamentous abnormalities that may be picked up, may not be picked up, but this is critical, right? Because not identifying these radiographic bony and ligamentous abnormalities associated with Chiari malformation can cause instability. And doing a posterior fossilic Chiari decompression will fail because that's not the only problem that's present, right? The problem is also these bony abnormalities, the ligament abnormalities, and these patients need oftentimes realignment of their spine, decompression, and then a fusion to stabilize that realignment that we just did. All right, so here's an example. There's a Chiari malformation. Tonsils go down through the opening of the skull. This is a patient with VACTERL syndrome. This is basilar invagination. This is a bone that kind of goes up too high. The second bone goes up too high, goes up through the opening of the skull. Okay, and this is the first bone in the neck. It's fused with the skull base. It's called atlas assimilation. And many of these other segments down here are fused. this child was born like this, okay? She's got brainstem compression on a different slice, better than this, that I'm not showing you. She had a syrinx down here. Ultimately, that patient, and I don't have it on here, but great. What we do is this patient requires traction to do traction during surgery. We basically, and then intraoperatively, we distract. So we place screws and rods, and we pull this down and push it forward. We do a decompression back here. We didn't even have to open the covering of the brain in this child. And then we realign the spine, and she did incredibly well. She had lots of brainstem symptoms, all resolved after surgery. So the last thing I'm going to talk about is dysesthesias that occur after someone has a large fluid cavity in the spinal cord, the syrinx, and that collapses, which it should do after surgery. Problem is when patients have very, very large syrinx, they had it for many years. Okay, it's different in kids. Since they're so young and they've had it for just a short period of time, they usually don't get this issue. This is more of a adult issue. And when the syrinx collapses, they'll get this new symptoms they develop in the extremities: numbness, paresthesias, weakness, dysesthesias, etc. These can be very challenging to treat. You try all the different types of neuropathic pain medications, Lyrica, gabapentin, pain clinic, but they can just be, and they can be new type symptoms. But it's difficult. Eventually they stabilize, but it can be quite frustrating because you have this amazing radiographic result, and everything's better, and you prevented anything from going on. Nothing's going to get worse in the future because you've treated the problem, but patients sometimes can even be, this new pain or new issue can be worse after surgery than their issues before. So the highest risk are these patients with a very dilated spinal cord, such as a holocord syrinx. And I'll show you an example, right? So this is, I think this is a 30-some-year-old woman that came to my clinic, and this is the large syrinx I showed you here, right? The Chiari malformation, and then standard decompression, open the cover in the brain, take down the adhesions, tonsils kind of come up, they look perfect, rounded, and you can see here the cord still has a fluid cavity in it, but it's going to, and I always describe this as when you blow up a balloon, right, you stretch it out, it's not going to come back down to its regular size, right? It's still stretched out once the air is deflated. And that's what's happened here. You've had chronic damage and compression to the spinal cord. Some scarring's occurred here, and it's not just going to completely go away. You're going to see the spinal cord all of a sudden now in the end. What you want to see is this is a shrinkage of the fluid cavity, and you don't want to see kind of the dilation of the spinal cord, the width here that you see here. You want to see it like this, which is kind of normal diameter. What you would typically see, it's just fluid still there, and this is good. There's no pressure now on the spinal cord, but this patient then developed pretty significant dysesthesias afterwards. So that's it. Yeah, thanks everyone.